Hello and welcome everyone. Today we are learning about smoldering multiple myeloma. Smoldering myeloma is the asymptomatic intermediary between monoclonal gammopathy of undetermined significance and multiple myeloma. Let's see the definition. Plasma cell infiltration in the bone marrow is around 10 to 60%. Monoclonal protein concentration in serum is over 30 gram per liter. Urinary M protein greater than or equal to 500 mg per 24 hours. Any one of these criteria and no evidence of other B cell proliferative disorders, no myeloma related organ or tissue impairment or bone lesions, and absence of myeloma defining events. What are the myeloma defining events? Such as end organ damage like hypercalcemia, renal insufficiency, anemia, and osteolytic bone lesions. It is important from a clinical standpoint to distinguish smoldering multiple myeloma from mgus because the risk of progression of smoldering multiple myeloma to myeloma is a 10 times higher than mgus in first 5 years following diagnosis. Risk progression. The new 2020 clinical risk stratification model given by Mayo Clinic incorporates 3 factors. First is serum M protein greater than 2 gram per dl, involved to uninvolved FLC ratio greater than 20, and bone marrow plasma cell infiltration more than 20%. To stratify patients with smoldering multiple myeloma diagnosed into low risk, intermediate risk, and high risk groups. If 2 to 3 factors among these are present, then it is classified into high risk group. If only one factor is present, then it is an intermediate risk group, and no factor is present, all factors are absent, then it is low risk smoldering multiple myeloma. 3 biomarkers for ultra high risk groups are bone marrow clonal plasma cells more than or equal to 60%, serum involved to uninvolved FLC ratio more than or equal to 100, and more than one focal lesion on MRI. These all biomarkers suggest ultra high risk groups. In 2018, a blood cancer journal published a statistical analysis of variable among patients with smoldering multiple myeloma at Mayo Clinic in Rochester, Minnesota. Further refinements to 2020 criteria were made with the addition of following 2 high risk factors. First is chromosomal abnormality plus 1q, a gain of chromosome 1q. And second is chromosomal abnormality deletion of 13q. If one or both of these abnormalities are found in FISH testing of myeloma cell, the risk of disease progression is increased. Clinical features. Smoldering multiple myeloma is asymptomatic. It can be diagnosed in following scenarios. In a patient who is being observed for mgus, in an individual seeking healthcare due to unrelated condition, or during a regular medical examination. It is recognized incidentally when patients are found to have monoclonal protein during workup of variety of different symptoms and laboratory abnormalities. Diagnosis. CBC is usually normal, may show rouleau formation. In bone marrow biopsy, there is 10 to 60% clonal plasma cells can be seen. It can be identified with CD138. Monoclonality can be seen as either kappa or lambda restriction by IHC. M protein identified in the serum or urine electrophoresis or immunofixation. Immunophenotype monoclonal plasma cell is seen. Molecular translocations can be seen such as translocation 414. 1114, 1416, deletion of 17p, gains or amplification of 1q. TRAF3 mutations may be seen in ultra high risk smoldering multiple myeloma. Treatment. Once the smoldering multiple myeloma is diagnosed, current clinical guideline recommends stratification to determine the risk of progression to myeloma and lifelong monitoring for progression. Traditionally, the standard approach has been observation until occurrence of myeloma defining event. However, early introduction of lenalidomide either alone or with dexamethasone showed a significant improvement in time to progression and prevention of organ damage in high risk smoldering multiple myeloma. So this is in short about smoldering multiple myeloma, and these are the references for this video. Hope you like it. Thank you. Bye. See you in the next video.